Privigen is working. All right, let's go here. And we'll go here. And we'll go back here. All right. All right, now we are recording, which is important. So this chapter again is nursing care of mother and infant during labor and birth. And so by now you've read the entire chapter. So let's go ahead and take a look at it and get you ready for exam 2. I believe this one also goes over the contractions and the 4 P's. What are the 4 P's of the labor and birth process? Anybody?
Powers, passenger, passageway, and psyche.
Yeah, you got it. So what's the power?
The contractions.
The contractions. Good, good, good. And what's the most favorable pelvis for a vaginal delivery?
Gynecoid.
Gynecoid. Good, good, good. What's the normal fetal heart rate?
110 to 160.
All right. Okay. What's the significance of late decelerations?
They're not good. Babies in distress.
Okay, so they're not what we call non-reassuring. Okay, so they're not good, non-reassuring, right? It can, right, lead into fetal distress. What causes late decelerations? Marquita. Come on, Tony, are you there? Come on here. Okay, good. So what causes late decelerations?
I'm not quite sure. Hold on.
Okay, remember, let's go back. Remember Vilchop?
Yes.
Yeah. So late decelerations is the L, and that is caused by uterine placenta insufficiency. You might write that down. Okay. Uterine placenta insufficiency. What that means is that the uterus and the placenta, they're not getting along that day. They're not, they're not sending the blood supply that is necessary for survival. Okay, because blood carries oxygen. And so if there's an insufficiency, then the baby, the fetus will take a hit. Okay. In that chapter, we also talked about culture, and how important it is. Is it important to be diverse and to be open to other cultures?
Yeah. Yeah.
Oh, definitely, definitely, definitely. So we call that culture sensitivity. Okay. And basically, we're respecting everybody else's cultures. And on birth is very important because it can influence her response to labor and birth. And I tell you, it comes under psychic, how her mind frame is during the labor and birth. I've had plenty of patients that, has different cultures, and let them do what they needed to do in the room as long as I could get to my patient. And I tell you what, it worked like a charm. Okay. My students know the story, Geraldine, but it's true. I had a patient that was of Indian American descent. And I tell you what, she asked me, she said, may I have my tribe in here? And I said, okay, how many is in a tribe? And I said, sure. So we had a big room, thank goodness. And they all came in and they all went around her bed and, they did their ritual. And I tell you what, she had a wonderful labor and a beautiful birth. Now, did that help her?
Of course, yeah.
You better believe she had a smile on her face the whole time she's in labor, and she felt such good support. They have a woman in labor has to have support. Okay, she has to have somebody there. And in labor and delivery nurses, we do fill in a lot in those roles. But there's another person I'm thinking about that she could hire. Okay, it's an upcoming thing. What's that? What's the name of that person I'm thinking about?
A doula?
A doula, yeah. And ever since we had this lecture that week, I've been getting so many things on the internet on doula. You can get a certification in doula, and you don't have to be a nurse to get that certification. You go through quite a bit because mainly you're giving support. You're not diagnosis. You're not intervening. You're there for the patient. I think it's great. Everybody has to have somebody. Okay. So maybe a test question could be on maybe tricking you up a little bit by putting culture non-sensitivity. Okay, what would the nurse, pick out the one that shows that she's not sensitive. Okay, and so you might want to read that question a little bit carefully, but anyway, that's kind of question to be on. Now, here, let me just move this over here. The influence of culture on birth practices, the nurse, and this is for all your patients, so you need to be sensitive to the specific needs of the patient. And the nurse's role is to be active and therapeutic what? Listener. Okay. And we have our, and then she demonstrates what? Culture sensitivity. All right, let's move on. So that was about one question on your exam. And then every group, every group has their specific needs. I'm thinking too of our adolescents and our single moms. They all have the specific needs. And what do nurses do? We respond to them. And also an interpreter. Now you may have a question on that. This always seems to be on an exam, but using an interpreter where appropriate. Okay, and we don't use a family member or anybody that has any kind of conflict with the family, right? Yeah, you're giving a lot of personal information out, and you want to use an interpreter. So yes, it's very easy to use a family member, especially when my patient comes in and she's completely dilated and wants to push, and I can maybe communicate like I want to because I don't speak her language. And it would be very, very, very tempting, but we have to get that interpreter in there. All righty. And then just a brief thing about dietary practices. Know that some cultures have the hot and cold, and one comes to mind is the Asian culture. They don't take anything cold after delivery, childbirth. They want like warm, warm water. Where we go, oh, we don't want to drink warm water, but yes. So just remember things like that. How about this? Here's a brain teaser. So now, which of the following nursing actions demonstrates culture insensitivity in the care of the laboring woman? See how I underlined that for you to show you culture insensitivity.
B.
B, right. That's exactly right. And that's how those questions would be asked. Okay, we already went over the 5 Ps. Well, we wanted 4 Ps. And the labor and delivery nurses, I hate to tell you, one right here, we put the 5 Ps. The other one we put in here is position, okay? Because position, mom is important during labor. You don't labor her on her back, never, never, never. So I put her on her side, and I can flip her from right to left. I can get them up out of bed, all kinds of different positions. And also I'm talking about the position of the baby's head, okay? We talked about occipital anterior, and where the back of the baby's head is facing to mom's interior, which is the most preferable for a beautiful vaginal delivery. That one, she can push the baby much easier during the second stage of labor. And so, yeah, I like my babies in OA positions. Now, OP is occipital posterior, where the back of the baby's head is now facing mom's her back, posterior. Now that baby is actually, if you think about it, I'll demonstrate to you the back of the head, and the back of the head now is facing to mom's back. Okay, so here's her back, here's her spine, and it's facing her back. Can you see my chin is like way up in the air? So that's how those babies are in there. And they can labor okay with OP. It's a longer labor, and the second stage of labor is longer. Like we like the second stage of labor, the pushing stage, to be between 30 minutes to 2 hours, the most too. But when you have an OP baby, that chin is way up in the air, it takes longer to push, okay? And then of course, OT would be transverse, occipital transverse, and he's just, his side of his head is just transverse in the pelvis. And that's a hard way to come down because you're coming down with the largest diameter of his head coming down the pelvis. So you want to change that OT some manipulation to change them to OA or even OP. It's better than OT. So that's on the position. So position is important for mom and for baby. And, moving mom around, like getting her up, maybe getting on the birthing ball, maybe her rocking, especially during the latent phase of the first stage of labor. We want to try to move that head and get her dilating. And also helps with labor. Okay, now we talked about the psychic, and the passenger is our little fetus. Okay, and hopefully he's about 7 pounds. Okay, these big babies, they're called those macrosomic babies. They're like 8.8 pounds to over 9 pounds, 10-pound babies. They're big babies. Not only is the head big, but it's their shoulders that are big. All right, so you can get into a lot of trouble delivering this kind of baby through the vagina because baby can get stuck. Okay, and then if the head is now delivered, and then you find that you can't, go any further, then the shoulders are stuck, and you have what we call shoulder dystocia, and that presents a problem to mom and the baby, because now we have to probably cut mom a little bit more, maybe give her a 4th-degree episiotomy, and so things like that happen. All right. Now the passageway, we talked about that, and the gynecoid pelvis. All right. And then we talked about the powers, and we said they were the uterine contractions. And contractions are necessary, guys. They're not only necessary for dilation and for effacement of the cervix, but they are necessary to help her push that baby out. All right. During the second stage, she still will have contractions. All right. Now that was, I think, a quiz question, if I remember. And so you want to make sure that she still has contractions during that second stage of labor. Then when she delivers, okay, now you deliver her, and now you have to get the placenta out, because that's what, the 3rd stage, right? Okay, right, got the stages of labor. And then you get the placenta out, and she's still got to contract, because she's got to keep that uterus firm and contracting so it can involute. Involution is the decrease, how the uterus goes back down to pre-pregnancy status. Okay, she has to have, and they're called at-the-birth pains. And at-the-birth pains are true. They're intermittent contractions, and they help push the rest of that endometrium blood out, the shedding, get out, and that's called the lochia. And they're necessary for the whole thing. I had a patient that said, I thought I had everything done. I thought I was delivered. I thought I delivered the baby. And I said, yes, you did. And you did a fantastic job. But yes, now you're having what we call the afterbirth pains. All right. So we kind of got the components of the birth process. Anybody have any questions? No? Okay. All right. All right. So this is why we do everything we do. Okay. We have a beautiful baby inside. We got to get that baby out. All right. So then on that chapter was really on how to go through the stages of labor. Anybody have any questions on the stages of labor? You got the stages of labor. The first stage is your longest stage, all right? And that has 3 phases. What are they?
I can't pronounce them. I know one starts with an I, intrarem. One starts with the A. And is the other one a P? I'm not sure.
Okay, so let's go over the stages of labor and write this down. Okay, the first stage has your 3 phases. And the first phase is going to be the latent phase, L-A-T-E-N-T, or early. Okay, and that's when she's dilated, I say from 0 to about 3 centimeters. Okay, and that's during the early time. I mean, your patient comes in and she's very nice, and she's like, how are you doing? Oh, Nurse Geraldine, you're so nice, and I'm so happy to be here, and I'm so excited. things are going great. And Nurse Geraldine gets her consent form signed, you know, and everything is good. All right. And she has a contraction, and then you help her breathe through it, slow chest breathing. And then she goes, whoo, okay, I got through that. Then she says to you, it wasn't so bad. And we go, okay. And so that's a good thing. Then the second phase, all right, she's gonna dilate a little bit more. What's that called, Maquita? What's that called?
Active.
Active, right? Active phase. And now she's dilated what? How many centimeters?
4 to 7.
Yeah, 4 to 7. Bingo. Yes. Okay. So now the contractions are what? They're a little bit closer together. And so the frequency, it could be every maybe say 3 to 4 minutes apart. And the duration would last about 60 seconds in duration. So they're a little bit more tougher, all right? And the active one, it's a good time for that epidural if she wants it. All right. It's a good time for an epidural. All right. Now, you got her there, and she says to you, I don't want any medication. Oh, okay. No epidural? No. Okay. So you help her breathe and cope with the contractions. All right. And what kind of non-pharmacological methods of pain management can you help her with?
Like sacral pressure and effleurage?
Yeah, effleurage is a good one. And if she has bad back pain, sacral pressure, the counter pressure helps. Hydrotherapy, getting her in a shower is a good thing, okay? Because the warm water running over the body, just so relaxing. And then all of a sudden you see this blood come down her leg. What's that called? That's that bloody show. Okay, the bloody show. I always love it when I saw my patient bloody show. You know why? Because I knew the cervix was dilating. I knew the cervix was effacing and dilating. So that's called bloody show. So yeah, so you can use hydrotherapy, effleurage, pelvic rocking, back and forth. Pelvic rocking is good. Walking, if everything is good, she's not on Pitocin, you can walk her. And this is where you can get the daddy or the partner involved, is with, rubbing her shoulders and everything. So that's always good. Okay, so you get her through that, but guess what? Now she's 8 centimeters, all right? And she's just getting what? Into the transition. Right, good, transition phase. And so she wants to push. So she says, Nurse Maquita, I got to push. And what's the response that nurse should get back?
Well, she can't push just yet, right? She has to wait till she's...
Yeah, you say, don't push, right? Say, you're 8 centimeters, which is good. I always put this in there. You're 8 centimeters, and that's really good, okay? And it's because I want to have a good positive one, keep her, feeling good. And then I say, but you can't push it. And I know you feel a lot of pressure, because if she doesn't have an epidural, she feels that head coming down. And that head's probably at 8 centimeters is at a good +2 station. So she's got a lot of pressure in her bottom. All righty. So she feels this pressure, but Nurse Maquita says, I want you to blow out the birthday candle. Remember I said to that? Blow out so what you're doing is you're making her make her cheeks puff out, when you blow a birthday candle. So try that. See how my cheeks are blowing out? When you do that, you can't push. Yeah, when you're blowing out, try pushing at the same time.
No.
Yeah, you can't push, right? So that was my trick. And it's true. Those are the short puffs, and you'll see that could be a good question. I've seen that already. So you might want to tell her to blow those puffs cheeks out. Okay. So now she's in transition, and you check her, and now she's completely dilated, and she's completely effaced, and she's at a +2 station. She's ready for pushing. And so you help her push, and A lot of times we hold the legs, okay, and we have these little foot pedals too, which are great, and we get them ready. And we get the delivery table. This is where our LPNs do fantastic work in the delivery room, is that they come in with smiling face and they said, I got you, here's our delivery table. I go, right. Okay, she got everything ready, got all the instruments. We got the radiant warmer in the room for delivery. Radiant warmer is on for the baby, right? Because what's the biggest problem an infant can have after delivery?
Like their thermoregulation?
Yes, exactly. Thermoregulation. I want to keep that baby what? Warm. Okay. Thermoregulation. Because write this down. Cold stress is never good for an infant. Okay. You don't want this baby to get hypothermia. Cold, cold, cold. Because what happens when a baby gets hypothermia, he can go into hypoglycemia. His blood sugar will go down, okay? And when blood sugar goes down, okay, he goes into respiratory distress. That's not a good combination. Hypothermia, hypoglycemia, and then goes into fetal distress. So we don't want that to happen. So the best thing you can do is have that radiant warmer in the delivery room, and it's on, so the baby's kept warm. And make sure you put a little cap on his head to keep what? We don't want to lose heat through his head. Okay, good. All right. So now we got our labored, okay, and you just birthed your patient, all right, and baby comes out. What kind of a score do you do on the infant?
APGAR?
No.
The APGAR score, right? And the APGAR score, what are you looking at? Well, what are you assessing?
Appearance?
Okay, appearance. So we got what? We got color, right? How about heart rate? Right, we'll make sure the heart rate is up there, right? Normal is still the same as it was in utero. And what about breathing? Want to make sure this baby's breathing, right?
Right.
So it should have 30 to 60 breaths per minute, okay? And then we're going to look at his muscle tone. So good APGAR score of 7 to 10 is good. So what do you do for a baby who has an APGAR score of 7 to 10? You just
I mean, it's
dry
not
them off, right? Just dry them off. Yeah, make sure, because babies come out, they're all wet. I mean, they're all wet because they've been in amniotic fluid. So they're full of fluid and they're wet. And then they hit this cold room and they could really get chilled very quickly. So we're going to get him warmed up. And you can do that right on mommy's tummy. You know, you can take the warm blanket and dry him off and then put another warm blanket over him. Meanwhile, he's on mom's chest, skin to skin. Beautiful for bonding. And then we put a little cap on his head, make sure he keeps warm. Okay. So we're going to do APGAR score, and a lot of LPNs help us out with that. They do APGAR scoring and dry the baby and rewrapping the baby, keeping the baby warm. So, you know, these are things. LPNs and RNs, we work pretty good as a team in those rooms. All righty. So now we got our baby birth. Okay. So now he's laying on mommy's tummy. And so now her body has to go back to pre-pregnancy status, okay? It took 9 months for that uterus to grow, right? So now after the baby comes out, where's that uterus usually? I'm talking about midline, but what level? Where is that uterus on mommy?
The umbilicus? Like
Yeah,
the belly
right
button?
right at the belly button. She looks like she's 20 weeks gestation after delivery. And I've had patients that would complain. They go, I thought I birthed this baby. Yes, you did. Okay. But your uterus has to go back down to its pre-pregnancy state. And so that process is called involution. Involution. Okay. So where it reduces, and it goes down, let's see, 1 to 2 centimeters per day. Okay. Now if she's breastfeeding, they can go down a little bit faster. Okay. And that's how I usually get my young moms to breastfeed, is I'll say, you want to get back into those skinny jeans? And they go, yes. like right now. And I go, well, we have to work on that. So if they breastfeeding, they will contract more, because when you breastfeed, you send a message to the brain and it releases the anterior pituitary, it releases oxytocin. Okay, so oxytocin is released a lot quicker, and so with breastfeed, that's really good. So that's involution. And the lochia. Now, lochia is the drainage or your bleeding. What it is the shedding of the endometrium out of the uterus. Because once that placenta comes out, all right, you still got a lot of good blood that's still up in there that was very nourishing to the fetus. So now that's going to come out. So she's going to shed. And that lochia rubra is the first bleeding after delivery. Now that can last up to 3 days. All right, it just depends, but lasts about 3 days. What it is like a heavy menstrual flow, real heavy menstrual flow. Okay, she's shedding that off. And then, so you want to teach her how to, to clean a perineum after delivery to keep it nice and clean. We use a little peri bottle and we teach them how to use that. And then after about 3 days, it starts to get a little lighter. So then we call that lochia serosa. Now lochia serosa is more pinkish, all right? It's not as red as the rubra, because now we're it's lighting up a little bit, but she still has a flow, but it's more pinkish red. And then after about 2 weeks on that, she goes into lochia alba. And alba is a whitish. It really more has WBCs in there, which are white blood cells and mucus. All right. And so that gets shed until about 6 weeks postpartum. So your fourth stage of labor, right, is your postpartum period. And that does last for the recovery in the hospital, which is, a couple of days you only have her in there. And then she goes home, and that postpartum period lasts 6 weeks. That's why we try to get women to, take it easy during those 6 weeks. Okay, not to have anything in the vagina for 6 weeks. Keep the vagina free, clean. Because if you had an episiotomy, the episiotomy, which is a surgical incision right down the center of the perineum, it's got to heal. Okay, if it doesn't heal, you get infected. All right. And infection in the episiotomy is very painful, as you can probably imagine. So we want to teach her how to keep it clean, like I said. So we have a little peri bottle, and you put warm water in there. And every time she urinates or has a bowel movement, she's going to take the warm water and pour it over her perineum. Okay. And going to take a little bit of toilet paper and just pat dry. Never wipe, just pat dry. From the front to the back, and disregard it. Now, we want to make sure she keeps it very clean. All right, good. And the vagina, too, part of the reproductive system going back to normal. The vagina will, the rugae, those vaginal folds in the vagina, they will come back. They kind of disappeared during the pregnancy, but they come back. Okay, and things will come back. So that's why I tried to tell the patients, nothing in the vagina until you come back. We check you, make sure everything is good, and that so that everything is there. The rugae is back, so intercourse would not hurt her. Okay, and then of course the breasts fill up after delivery because a woman is to feed her baby, and so if she's feeding the baby, that'd be good. Every 2 to 3 hours. It's very demanding, and has to keep the nipples clean. All you tell them to do is wash it with what? Warm water, and keep it clean. All righty. So let's go on here. Let's talk a little bit more assessing the episiotomy. All right. So you got the surgical incision. You can either have a midline, which is straight down the perineum, or you can have a medial lateral. It's over to the kind of a few centimeters over to the left of the perineum. And they need special care. You have to assess them, okay? You have to assess. And we use the acronym REEDA, REEDA, all right? So R stands for redness, And the first E is edema, swelling. Okay, because that area gets swollen after deliveries. And then you have ecchymosis, which is bruising. Okay, so you got bruising. And then, of course, if we have to suture you up, so we have to use sutures. And we use very fine little sutures, and they will dissolve. Okay, they do dissolve, so there's no removing sutures out of that area. And you want to make sure that when you looking at the sutures, they approximate. So approximation is, here's one part of the tissue and here's the other part. Okay, so now we're going to bring these together. So we're going to sew up the middle. So sometimes these sutures will kind of give a little, okay? And so you may have like a millimeter, a little gap in there, but it shouldn't be too much. And that's why you don't want your patient to be constipated after delivery, because you don't want her to push, all right, push the stool out, because then she could break open those suture lines. And you want her to have a nice, you want that incision on the perineum to heal just perfect. You know, you don't want her to have any messy scar down there, because that's her life, that's her future. So you want to make sure it heals good. Okay, so what am I going to give her right after delivery to help with the ecchymosis and the edema and the redness? What should I apply to her perineum?
Ice coldness, ice packs.
Ice packs, you're right. Get a nice cold ice pack, okay? I'm going to tell you, those cold packs they have in the hospital, you know, they're the chemical ones, you know, you pop them, you know, they don't get really, really cold, okay? So when somebody has a 3rd or 4th degree, I make my own ice pack, get a glove, put ice in it, and put her on perineum. And she goes, thank you. Okay, because that really works. Okay, so you got the cold packs. Now, if they have that episiotomy, you may have to give them a little bit of more Epifoam or Duraplast. Those are medications that are topical that can help out with the healing process and keeping things clean and take a little bit of the sting away from the suture line. Because don't forget, those are sutures, they got to pull, all right? And so you got to make sure that she is comfortable, okay? Because uncomfortable moms don't want to be bothered with breastfeeding or anything, right? They're hurting, all right? So you don't want her to hurt. So we want to make sure that we address her pain. And sometimes we give Percocet afterwards during the postpartum period on the unit, only to help them deal with some of the discomfort, especially guys if they had a 4th degree episiotomy, because the 4th degree goes all the way back, right, to the anal sphincter, right? So that's all the way deep. That's all the mucosa lining tissue, right? And so it's very painful. Right. And then don't forget, we have to sew that up. Okay, and so that's why those big babies, you know, we have to cut an episiotomy for those big macrosomic babies. You know, that's what you're having. And we call that 4th degree episiotomy. This is what we named it. We named it a C-section from below, because that's what you're cutting. You're cutting way deep, okay? And then the perineum is completely open so that you completely can get the baby out. Hard, very hard. Okay, now she will have return of ovulation in her menstruation again. Now, if she's breastfeeding, she might not see that. Okay, it may be delayed because breastfeeding will do that. All right, good. Okay, but you have to tell her, if you decide, you know, that you're not going to breastfeed as much, and maybe you're not going to do 10 times a day, then you might want to use another form of birth control when you do have intercourse, okay? Then you got to tell them, because they're going to go home, they might have intercourse, and they think they're breastfeeding enough and they don't. And then all of a sudden they ovulate, and then they're back in your office when you come back for 6-week checkup, okay? And you have little gifts again. So you want to make sure that, you know, you tell them all these things. So to keep her from ovulating, she must breastfeed at least 10 times a day. All right. Again, the breastfeeding is great because it does release oxytocin, and which will help her uterus contract. Okay. All right, so let me give a little brain teaser here to you. Okay, so which nursing intervention should the nurse include for a client immediately after delivery to reduce bleeding and bruising of the perineum?
D.
D, right?
Mhm.
D, yeah, D, good, okay. That's how that question may do it. Now, okay, so now we're talking about the uterus, and so the uterus is gonna what? It's gonna involute afterwards. And these contractions that we talked about earlier, these are the different phases of a contraction, just in case this may come up. So contractions are necessary for effacement and dilation. We talked about that. Contractions are necessary for the involution process. So we talked about that. So these contractions have 3 phases, okay? The phases are increment, the peak, and the decrement. So what you have to know, let me show you here. What you want to just take in consideration is only increment is increasing, okay? The intensity of it is increasing. She gets to the top, the peak, that's the gun ho, that's the big one, okay? That's the highest is going to get on that contraction. And then she has a decrement, which decreases, okay? And so this is when we talk about the contractions before, and you guys got this down packed really good. And you got duration, because you may see that term next week, okay? Duration. So that's the time element from the beginning of one contraction to the end of that same contraction, okay? And so read those questions carefully, okay? A lot of students I'm gonna tell you what they get mixed up on. They mix up with duration and frequency. And that's why when you're studying, you want to say it out loud so that you don't get it mixed up, okay? So duration is from the time, see, okay, let me show you here. Let me get my little pointer. From here, right? From here to here, which is that same contraction. That's duration. So in other words, how long is this contraction lasting? How long is it lasting? Okay. Now, when you talk about frequency, and of course, when you talk to patients, they're not going to say, well, the frequency of my contractions are. No, but they also say, how they put it, they say, oh, they're coming every 2 minutes or every 3 minutes. That's how they say it. But frequency, the definition is from the beginning of, say, one contraction to the beginning of the next contraction. Okay, so it's from one contraction here, see, this is frequency, and then all the way to the beginning of the next contraction, okay, because that's when the next contraction starts. That's frequency. So be sure to read those questions carefully when they're asking what duration and frequency is, okay, and then you'll get it. Now, breathing, to help your patient get through this contraction, during the increment time, she wants to do slow chest breathing. Slow chest breathing during the increment. When she gets to the peak up here, you want to do more of a faster rhythmic pattern. Like I'll demonstrate to you like this. When it really gets intense, they'll go faster. And then as soon as you can, you guide her down, okay? And when she gets into the decrement, she slows down the breathing, all right? So that's decrement. If you don't, and she keeps up that fast pace breathing, she could hyperventilate. So how do you help her to come out of that hyperventilation state? What do you tell her to do?
To breathe in her hands, the cup hands.
Yeah, so take your hand and put it over your nose and your mouth like this and breathe. Just breathe. And sure enough, she'll blow up that CO2 and she'll feel a lot better. What happens with hyperventilation, and it makes them feel really odd and their mouth gets all tingly. And so you want to make sure she comes out of that. That's why you're coaching her during this time. Okay, you're helping her breathe. If her partner is not helping her get through this and she's just breathing all over the place, you, the nurse in the room, will help get her through this. Okay, all right, okay, all righty. All right, so this was just my definition. Wasn't definition, duration, we did that. Frequency, we did that. Okay, now the last one, how does the nurse assess intensity of the contraction? Well, let me go over that with you. So that's going to be by palpation. All right. So what happens is you have external monitoring on. All right. When external monitoring is on, you have the tocodinamometer, which is on the fundus of the uterus. Okay. That picks up the contractions. Okay. Then you have the heart, you're monitoring his heart rate, and you have what we call the ultrasound transducer on the baby's back to pick up what? Pick up his heart rate. And so you want to know how strong these contractions are, because your patient may be breathing really fast and you're going, they don't look very strong on the monitor. I better palpate the uterus. So what I'm going to do is you take 2 fingers and you just gently put the 2 fingers on top of the uterus, okay, the fundus, which is the top of the uterus. And I'm just going to feel how strong that contraction gets when she has one. All right. And then they can be mild, moderate, or firm. All right. So take your finger and touch your nose. Everybody touch your nose. That's a mild contraction. See, that's what it feels like. Okay. Now check, touch your chin. That's a moderate contraction. Okay. Now take your finger and go and feel your forehead. Your forehead is firm, right? Okay. So that's a good contraction. Is that firm? Okay. All right. So mild, moderate, firm. All right, good. And that's how we teach new nurses in the labor room. We teach LPNs are going to come back and help us. That you know how to palpate contractions, and only 2 fingers. And you use the tips. You don't use the palm of your hand. Go, I'm going to feel how strong your contractions are. You don't do that. Just the 2 fingers. Okay. All right. Because if you did the palm of your hand on our uterus and she's having a contraction, she'd probably slap you. Okay. All right. It gets intense. Now, another term that you can see too would be a Braxton Hicks. Okay, so Braxton Hicks contractions are irregular contractions. Okay, and they can show up in the early pregnancy, and then they get kind of scary. So we do hydration. We tell our patient to drink a lot of water and to calm them down. And they can also show up again when she gets more toward term. Okay. Now it's more annoying at the end when she thinks she's in labor, because she keeps coming into your triage room and thinking, I'm in labor, you know? And meanwhile, the contractions are so irregular, they could be 5, 7, 10 minutes apart. Well, those is not true labor. All right. So true labor is really the rhythmic contractions frequency every 2 to 3 minutes. The duration can last from 60 to 90 seconds, and they palpate moderate to firm. Now that's a good true labor pattern. All right, you got that? Okay, so in irregular, so when you're triaging and you're trying to figure out, I'm gonna send this lady home or not. I'm going to monitor her blood pressure. I'm going to take the baby's heart rate in consideration, make sure everything is good. So I sent her out walking. You know, you see a lot of ladies walking those hallways, and to see if the contraction will intensify. Okay, because walking, now you might see this in some kind of form of a question. Walking is your best way to judge if she's in labor or not, because walking, if she's in true labor, walking will help it get better. It will make those contractions more frequent. All right. If she's not, if she's in false labor, those contractions will dwindle out. They won't do anything. All right, they'll dwindle. They'll like get real spaced out. And so she comes back and she says, no, my contractions are not, you know, they really are far apart now, you know, and they're not as bad as they were when we were home. Okay, so, and then you check her for dilation and there's no change in the cervix or the effacement, and you go, it's not time. Okay, and they get upset, you know, because they want to be in labor and get this process done. But those are those Braxton Hicks contractions. They just can get annoying, you know, especially if it's 2 or 3 o'clock in the morning. All righty. So one of the chapters had about passenger, the fetal lie. So I'm just going to show you here, in case that you had any questions on lie. Lie is how the baby is positioned in utero in relation to mom's spine. Okay, so you have imagine it, look at the mom and you see her spine. Okay, all right, kind of imagine there. All right. And so this baby here, this guy here, he just found a different way of positioning himself in utero, and that is called the transverse lie. All right. That one, he's transverse in relation to mom's spine. That's all that is. It's called position. Okay. And this one here, this little guy here was smart. This is the A student. He put his head down in an OA position, and he's ready. Okay, again, so now this is what we call cephalic. Okay, head first. All right, cephalic position. And so you can see he's in a longitudinal lie, you know, according to mom's spine. That's all that is. All right. Okay. Now, in that chapter 2, they had about the presentation, and these are all different presentations. Okay, a little complex, all right? But, you know, what I want you to know basically is we went over the OA and the OP and the OT already, but these are a little bit more. Here you have a shoulder presentation. You can see what's presented. What it is what's presenting down by the cervix, and he's in a shoulder presentation, okay? That little guy, he just got himself in more like a transverse lie, and he is got his shoulder that's now coming through. The shoulder is presenting, not the head, his shoulder. So that is a C-section. Okay, that's a C-section. Transverse lies are C-section, by the way. Next guy here, this is called a Frank breech. I call him Mr. Frank. This is how I learned it, like, oh, a long time ago. Because he puts his feet up by his head. He just wants to show everybody who he is, okay? So that's Mr. Frank, all right? And this one's a C-section. And then you have a full breech. Again, what's presenting on here? What's presenting? You tell me. The buttocks. The buttocks. The sacrum is presenting. So, you know, these would be C-section. And here, this guy here, he's ready to come out. He's got his foot already started coming through the cervix. And so this is your single footling breech. He's ready to come out. He definitely would be what? A C-section baby. All right. Now you probably saw this in your book when you were reading and thinking, my goodness, what's all this about? Again, we talked about OA position. Okay. So here in the OP, all right. So here's mom. So here's her posterior, her coccyx. So you can see this is quite, you know, intense here. Be a lot of nerves. And look at your interior. Okay. So when you're looking at an ROP, okay, it's an occipital posterior. So his back of his head is to mom's posterior. Okay. And so his chin, you see the chin? The chin is up. Hard to labor. Okay. A lot of back labor. These babies, babies like to get themselves in an OP position in the beginning and during the latent phase. Okay. And so, you know, she has a lot of back labor. That's where that sacral counter pressure comes in. You want to get in there and really rub, really put that pressure on there to help her to cope with that. And hopefully walking around will help move his head around. Okay. And then he's just laying on mom's right side. And here's your LOP, left occipital posterior. Okay. And then here is the picture of the occipital transverse. Okay. So the main thing what you need, you'll probably say test question on would be, you know, can she push? Is what stage is elongated during what OP position? It'd be the second stage. Okay, pushing becomes a little bit longer in duration. All right. Any questions about fetal presentations and position? Kind of makes sense now, huh? Everybody good on that? Okay. All right. We already talked quite a bit about the psychic and the cultural and individual values, how they influence how she deals with childbirth. Let's go on here. We talked about already a little bit of Braxton Hicks contractions. Okay, I always tell my patient when I have to send them home, and they go, you know, they get very discouraged. I say, well, Braxton Hicks is like the body's trying to get, you know, going. All right. And so labor will come, and it looks like pituitary is, releasing some oxytocin, which is good. It's just that we need to get them to be a little bit stronger and regular so that we can get dilation and effacement of the cervix. Okay, that's usually my spiel. And then you might see increase in vaginal leakage or discharge. Okay, and bloody show. That mucus plug come out. That mucus plug, you studied that a while back. The mucus plug is important. It kept a lot of bacteria from ascending up into the uterus. So now when she goes into labor or impending labor, that is released. And a lot of women get very excited because why? Because they think they're going to go into labor right away. Okay. The labor will come. Okay. And so the body's starting to get ready for all that. And then another pretty good sign of impending labor would be rupture of membranes. She had a spontaneous rupture of membranes, all right? And so I always tell my patients, if your membranes rupture at home, please note the time and color of the rupture, okay? I want to know what color it is. It should be, what color should amniotic fluid be? Clear, right? Clear and don't have an odor. All right, good. All right. So and the time, because you have 24 hours to get her delivered from the time of rupture. Okay. All right. So let's just move here. Does everybody understand birth station? Okay. Everybody, Marquita, you got it? Here's you have the ischial spines right here. Here. And so they are very prominent when you go and do a vaginal exam. You can feel them. And I use that as my landmark. Okay. So that's my 0 station. And anything that's above my ischial spines is going to be rated as a minus, negative 1, 2, 3, 4, 5, so on. All right. That means that baby's head would be really up high and not engaged and floating. It'd be more palatable. And then here, anything below these ischial spines is rated as +1, +2, +3, +4, +5, okay? And by that time, the baby's born. And then you would see crowning. All right, so this is when we talk about how dilated our patient is and what station the baby's head is. She's 8 centimeters, completely effaced, and the baby is at a +2 station. You can see where the baby's head would be. We're ready. We're doing good. Okay, we're getting closer and closer to delivery. So now you can see at a +2, +3 station why she would feel this intense pressure at 8 centimeters to push. Okay, because it's baby's right there, and she feels like she's got to get it out. Okay, so it's pretty tough. So remember, puff your cheeks and don't push. The reason why you don't push before 10 centimeters is because you can damage the cervix. You can make the cervix edematous, all right? And if you do that, it's very hard to take that swelling down, as you can probably think. So we don't want no pushing before, because you can make it worse for her. She can even rip her cervix, okay? So you don't want that to happen. All right, let's move on. We talked already about false labor and true labor. I may have a question on that. And the false labor is just that the contractions are irregular, goes to the Braxton Hicks. Walker relieves contractions, and your bloody show is usually not present in false labor. That would be more in true labor. And just something too, in true labor, your contraction pattern is a regular pattern. Okay, and they become stronger and more effective, and they dilate the cervix, and there is bloody show that does happen. The reason why there's bloody show is because when the cervix, which is a very vascular area, remember the Chadwick sign, which is, you saw that congestion in the cervix in the beginning of pregnancy. It's a very vascular area. So when that opens up, you'll get bleeding, okay? And you'll get mucus mixed in with that, and that's why it's called bloody show. Okay, so that's the difference between both of them. Let's hit it a little here. How about a little brain teaser? As you can see, Geraldine, my brain teasers are questions. I usually like to put it that way. A laboring woman is uncomfortable. Okay, so she's laboring, and she's uncomfortable, and her labor has slowed down. Oh, dear. So which instruction should the nurse give to the client to help stimulate labor?
B.
B.
D, yeah, encourage her to get up there and ambulate because that will help stimulate those contractions, okay? All right. I just put this in here just so that you have an idea of what fetal monitoring is all about, electronic continuous monitoring. And that's a standard practice in all facilities in the labor rooms. And this is a Hewlett Packard machine, okay? And you have blood pressure, pulse oximetry, you got the fetal heart rate, you got the tracing, and here you can see the tracing, and you can see the tracing. Let me here, make big. You see those good accelerations? Remember, accelerations are A-okay. Accelerations tells us that the baby is getting enough oxygen in utero. So he's doing okay. All right. So that's a good sign. A-okay. All right. Here's a typical labor room. She got a wedge underneath her hip there. She's not totally on her back because we never labor anybody in supine position. But here's the top belt. This is the TOCO. This is, okay, let me get my pointer here. The TOCO is right here. This is the fundus of the uterus. So this is where I put that monitor here to pick up uterine contractions, okay? And then here is to pick up the fetal heart rate, electronic transducer right here. And then these will be connected to the monitor. See these little plugs here? That's what they're plugged into. And then here's her blood pressure cuffs on, and is the monitor. So this is a typical case that we put the monitor in. It looks nice, like a piece of furniture. Doesn't look so institutionalized. And this is the birthing bed she's in. This will be the birth bed that she will give delivery to. Okay. All right. And then here's another picture of a monitor just to show you. All right. And then let's go here. So when you're evaluating, we'll go over this just briefly. Evaluating fetal heart rate patterns. This is how they categorize. So your baseline fetal heart rate is 110 to 160, like you told me before. And anything below 110 would be fetal bradycardia. And anything greater than 160 would be fetal tachycardia. Okay. Now you may see some bradycardia, especially if she if you have her on her back, the baby's not going to get enough placenta perfusion, and so therefore his heart rate will go down. Or you gave her an epidural, and her blood pressure became what we call hypotensive, right? Low blood pressure. Then that will affect the fetus. One thing you got to remember is that whatever affects mom will affect the fetus. Okay. And so then we have some what we call beat to beat fluctuations, and these are called variability. These are beat to beat. So write that down. Variability is beat to beat fluctuations. And let me go back to show you. Let's see here. This one here. Here we go. And I call these little squiggly lines, okay? And they're beat to beat fluctuations of the fetal heart rate. And we like to see these up and downs, beat to beat, up and down, okay? That means I got variability. And so from 5 to 25 is moderate. We're good. We're good. We're getting enough oxygen. When you don't have these, and it's more like it gets very minimal, all right? Because then you have less than 5 beats per minute. Your baby is it's not getting enough oxygen. It's hypoxic. So you don't want that to happen. So you want the baby to get enough oxygen. So keep that beat to beat variability going. All right. So that's part of the variability, and absent variability is never good. All right, because absent variability means there's nothing, and that baby is sick. All right, time to get the baby out. Okay. Remember VLCHOP. All right, so you may have a question. Maybe you have to recognize what not recognize, they'll ask you about, head compression, early decelerations caused by what? Head compression, right? Accelerations, A-okay, baby's getting enough oxygen, okay, it's good. Late decelerations are uterine placenta insufficiency, right? And variables, those variables, they're caused by cord compression. And so it can happen where you got the patient laying and how the baby's laying inside, the baby's laying on his cord, all right? So you got to move mom, reposition mom, so you can reposition that baby off the cord, all right? So those are things that we look for, and they're variable, so their shapes are varied. Now, sometimes you see it as a V, which is a sudden drop with a sudden recovery. Sometimes you see it as a W. That means that I laid on my cord, I recovered, and then I laid on my cord again, and then I recovered. That's a W. Or it could be the shape of a U, all right? And so variables are okay. I would, use that, what's that mnemonic lion, Lion, left lateral position, right? IV, oxygen, and then call for help, okay? When you have decelerations, you want to use that. Remember lion, okay? Left lateral. Make sure her IV is in, or if she needs one, get one in. And then oxygen, and usually 8 to 10 liters via tight face mask, with a tight face mask on. And then of course you need help. Get a doctor in there, get somebody to help, and that's lion. And a lot of times when you have like a test and you have like a scenario, and they'll go through and give you a description of everything's happened, then you start thinking lion. You go, okay, I got to change the position. Let me see the choices in the questions. Make sure you take your time and read the questions, because a lot of times students will go ahead and jump, and then they go, oh, I didn't see that. Okay, when we look at the question itself, I didn't see that. So make sure that you read the whole scenario on that question. And I'll tell you another thing. I always share this with every class I have. Ask yourself, what is that question asking me? Yeah, and you ask yourself when you're reading the question and you go, you think, what's this? What is this question actually asking me? It's giving me a whole bunch of distractors, whole bunch of information here. But what is the question actually asking me? And when you do that, it takes a little bit of a time, maybe another second, and it'll show you. Okay, it really will. So just keep that in mind. All right. All right. So here's like a late deceleration. Even though you got some squiggly lines in here. Okay, remember the squiggly lines are your beat to beat fluctuations. All right. I lose it here. See here, I'm losing it here. And see over here now, I'm losing it. And I'm having late decelerations where the lowest part of the deceleration is after contraction. So this is not good. Okay, my baby's in trouble. And this lower part of the deceleration is called the nair, N-A-I-R. So you want to look and see where your deceleration is and go, oh, this is not good. Okay. So if she's got like Pitocin running, say they were doing induction of labor and she's got pit running, they would definitely shut the Pitocin down. All right. Because I don't want her to have any more contractions, because this baby is not tolerating the contractions. Okay. Can't tolerate it. All right. So I don't want to make this baby any more distressed inside. So I'm going to what? I'm going to shut off the Pitocin. And that's what that says. This is oxytocin off. Okay. That's part of the nursing interventions that you do. So you do the lion and plus you shut the pit off. All right. So a nurse is caring for a patient in labor, and she knows that the fetal heart rate is in the 90s. Okay, so we got bradycardia. And it says here, I think it says here after contraction. All right. So what priority intervention should the nurse perform? Well, we definitely wouldn't increase the patient's Pitocin, right? Turn the patient to the side. Yeah, right. So what was if she's in the 90s and during a contraction, what are you going to do? If she's laying on her back?
Turn her to the side, left lateral.
Yeah. I turn her to the side, and then, you want to make sure that you notify somebody, right? Yeah. All right. So here's your amniotic fluid. I think we talked about this and you all know it, so it should be clear. Now, what happens? Let me ask you
Professor,
this.
I'm sorry.
Yeah.
The question, which is it? Because you're saying turn on the side, then notify, but which is it that the
Now, the question-
priority?
Yeah, what do you think?
Well, I saw the baby's in danger now, so I was gonna notify the provider, but I'm not sure what you said first.
Yeah, if I had to do one thing before I left the room.
Okay.
Yeah.
So
Yeah.
turn the patient to her side.
Yeah, because I mean,
Okay.
if I leave her in the position she's in, it's only gonna get worse. Yeah. But if I can do one thing before I leave that room, yeah, and then
Okay.
I stick my head out the door and say, I need help. Okay.
All
And then I got
right.
my IV, right? Got my IV, and then I got my oxygen. And yeah. So I follow that line, but yeah, I call for help. Mhm.
Okay.
You got it. Yeah, good.
Thank
Thank
you.
you. Yeah, thank you. Hi there. I didn't see you come in. Hi there. Um, all right, we talked about amniotic fluid earlier this morning. Okay, so we know it should be clear. All right. What does it mean when it's green?
Meconium.
Section.
Yeah, it's meconium. So, can I labor her with the meconium?
I delivered my daughter with meconium, so yeah.
Yeah, that's shaking my head. Yes, you can labor her, but okay. So, you're more of a high risk. We're going to keep a closer eye on the patient, the fetal heart rate, make sure that he doesn't get hypoxic on us. And then what happens at birth? We have to get the meconium out of the baby, right? So when the baby's head comes out, we suction. Use wall suctioning and get as much out of the oral cavity as we can, right? And then baby, next contraction, the baby is delivered, all right? And so we don't stimulate that baby to cry. No. We don't stimulate the baby to cry. We take the baby over to the warmer, and you would have RT, respiratory therapy, and you would also have the NICU nurse in there, okay? And they'll intubate and go down deeper to get as much meconium out of there. Why do we do that?
I would think maybe if you try to stimulate the baby to cry, the baby can aspirate, maybe.
Yes, the baby will aspirate if we stimulate that baby to cry. So it's kind of very intense time, as you can imagine, because you don't want that baby to take that beautiful cry. You want to hear that, but you don't want him to do it because you don't want him to aspirate. Okay, because when they aspirate the meconium, it goes into the lungs. They have meconium aspiration syndrome. All right, and they're very sick babies. Did you have that, Geraldine?
Yeah, me and I spiked a fever, so they weren't sure if she had aspirated it, and we both were on antibiotics right after she was born. She had a little board on her arm.
Yeah. So they go to NICU and they'll get a little IV, and they do treat them with antibiotics, okay? Because meconium, I mean, that's pretty thick stuff, and they get that into their lungs, they can do a lot of damage to their lungs. Okay, that's why you want to avoid the meconium aspiration. All right. Odor. Amniotic fluid does not have an odor. May have a slight, but nothing foul. Anything, when you have a foul odor, what does that represent?
Infection.
Infection, yeah. And then of course you see how much of the amniotic fluid came out. All right. How about another little brain teaser? Let's see if we can do this one. So a woman in active labor experiences spontaneous rupture of membranes. So which nursing actions are appropriate at this time? Select all that apply.
ABCD.
Ah, ABCD. So that would be a good question too, wouldn't it, huh? Yeah. Okay. Good. You're right on track, guys. All right. We talked about doula already, and here it is. They're just specially trained, and anybody can get certified, but we talked about this earlier. But the main thing about a doula is just helping the woman cope with labor. All right. Labor is a marathon, no doubt about it. All right. I had included this in the very beginning. So stages and phases of labor. Anybody have any questions about these stages and phases of labor? We talked about this already, but anybody that wasn't here earlier, have any questions? Remember, the third stage of labor is the delivery of the placenta. Now let's talk about that, okay? Because that can incorporate down the line in another chapter. But third stage is you're going to deliver the placenta. Now the placenta takes time, okay? It can be from 5 minutes to 30 minutes, all right? Or legs are up, and you got to make sure that placenta breaks off from the endometrium, all right? So we're going to look at the placenta when it comes out. All right. So we don't pull on the cord to get the placenta out. No. When I see a physician starting to do that, they take a hemostat, okay? And they take the hemostat and they start wrapping the cord around the hemostat. So they can put a little bit of counter pressure like this, And I look at them and go, no. I do not want you to break that placenta off. First of all, I don't want the cord to break off. You couldn't pull the cord off, okay? And then you've got a placenta up there that you got to get out. You've got to take the patient to surgery. But we don't want that. So we want that to break off the endometrium. So now it broke off. All right. So mama's side, the maternal side, is called what?
The Duncan.
Duncan.
Yeah, good. And I learned, I'm gonna tell you, Geraldine, and Maquita said it. I learned it as the Dirty Duncan, okay?
I remember you saying that in the last review, the Dirty Duncan and the Shiny
Schultz.
Schultz.
Right. And see, it stays with you, it stayed with me all these years. So anyway, so you want to look at it. And the reason why you want to look at it is because you want to make sure you have all the lobes, all the pieces to the maternal side, okay? Because that's what was up there attached to the endometrium of the uterus, all right? So those things can break off, okay? And they can get stuck to the uterus. And then you have a condition called retained placenta fragments. Now, that's a big problem because mommy can hemorrhage. And then you end up having what we call a postpartum hemorrhage. And you've got to get that pieces out. It can be small pieces, real small, okay? But it'll cause her to bleed. Now, also, she could have a small piece. Nobody picked it up yet, okay? Her lochia wasn't too bad. It was red, it was rubra, had a few clots, but she went home. This is where we teach them about remember I said the color of the lochia, how it should change to serosa. If she wakes up one day and it was serosa, like the day before, and all of a sudden now she's got bright red bleeding again, we tell them to get back to the hospital. Because what happened was that little piece of placenta was still in that uterus. She has a retained placenta fragment. And we have to get that out. Because otherwise she'll keep bleeding, see, and she'll hemorrhage. And then you got a patient that goes into hypovolemic shock, and you can lose your patient. Okay, you can go into DIC. I mean, you're going to have so much complication from a retained placenta fragment. All right, so that's why we want to get the placenta. And we gave the placenta a whole stage to itself. Okay, a whole stage. It's very important to get the placenta out. All right, intact. All right, and then we look at it. Shiny Schultz, neonatal side, Dirty Duncan, mommy side. Everything's in place. And that's where my LPNs, and when we have an LPN in the labor room, we'll say, I'll say, Kanisha, go look at the placenta and make sure that everything is there. And she said, oh, no problem. I learned that in school. So she'll go and she'll what? She'll look at the placenta. Oh, I just lost Keisha. Okay. All right. So anyway, you got the placenta, and then you got the fourth stage, which is your recovery or your postpartum. And then you got your second stage. Anybody have any questions? Because this is a good test questions. Okay. All righty. All right. So here, let's talk a little bit on chapter 7. It was on pain management. So definitely know your non-pharmacological means of pain management. Because some patients don't want an epidural, okay? Some patients want to go all natural, and that's okay. So that's where you go in the hydrotherapy, the effleurage, and different position, breathing, all those, all right? And one way too, if you can't remember all of them, on a test question, just say to yourself, now which one requires medication? I know an epidural requires medication and a pudendal block requires medication. Because they gave you choices and then you have to pick out the non-pharmacological, okay? So you want to choose the ones that don't require medication because she doesn't want any medication. So think of that way. That's another way of thinking about it. So pain management, here's your epidural. Main thing about epidural you have to worry about is hypotension in mom, okay? So we'll give an IV bolus and like 1,000 mLs prior, as long as basically she is not hypertensive, doesn't have any preeclampsia, we can do that. And the reason why you're doing that is because once she gets the epidural going, a lot of times the blood pressure of moms will go down. If you got a bolus already with some extra fluid, she'll maintain stability, okay? And then mom's good, right? Baby will be good, all right? If mom's blood pressure goes down, baby heart rate will go down. All right. Epidurals work good. Remember what phase of labor is it good to give an epidural in?
Active?
Active. Good. See how that question can be asked? Active. Good, good, good. When should you not give a narcotic to a laboring patient?
Transition?
Transition. Okay, good, good. Does everybody understand why you wouldn't give a narcotic in transition? Because the baby will be sleepy at birth, okay? He'll come out and go, hi, and then go to sleep. And so what medication kind of counteracts the mechanisms of working of an opiate? What
Counteract?
yeah, what kind of
Nar-
medication, huh?
Narcan? Naloxone?
Yeah, you got it. Okay. And we do that for babies. We have it right there ready for them. Okay, the pudendal block is given only during the second stage, okay, of labor. She's pushing. And the reason why is maybe you need to do an episiotomy. So you want to anesthetize the perineum. Yes, that's kind of nice to do. And so we'll go in with a long spinal needle right into the pudendal nerve on each side of the perineum and anesthetize, okay? And now we can do an episiotomy, or if the patient needs an assisted device to deliver her baby, like forceps or a vacuum extractor, we can put that in a lot easier because she's now anesthetized her bottom. You know, it's nicer. So that's why we do pudendal. Now, a good test question would be, during what stage of labor can a pudendal block be given? And you would say
Second stage?
second stage. You got it. Okay, good. All right. So that's how you put that together. Good, you got it. All right. We talked about this already, the non-pharmacological. I know you'll see this, okay? There's always a question on the non-pharmacological techniques of pain management. And so you got those skin relaxation, you got effleurage, sacral pressure, thermal stimulation, imagery. I use a lot of imagery with my patients, and of course the controlled breathing, all right? There's 3 different methods of child preparation classes, Lamaze, Bradley, and the degree. They're all good. They all got the same type of controlled breathing, mommy being in control of her own body, okay? And so therefore you need support person to help her, and therefore if she doesn't have anybody, you have the doula. Got it. All righty. Talk a little bit about vaginal birth as a cesarean. They're called a VBAC, okay? And what you're doing is mainly if they want to say their first baby was a cesarean, and because the reason why is because the baby was in a breech presentation. And so now she says, this is my second baby. I really don't want to go through that again. I'd rather have a vaginal delivery. So, okay, so we're going to labor her. But there's a couple things. She has to go into spontaneous labor. You cannot give her Pitocin. No, 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 because you could rupture her uterus. So she's got to go into spontaneous labor. And you cannot at all give her any kind of Pitocin, either augmentation of Pitocin, no. And you have to make sure what kind of scar is on that uterus. It has to be a transverse, or we call that fan and steel incision. And it is like a low bikini cut. And you got to make sure you see down the skin, but you got to make sure that they did the same cut on the uterus. Because if it's a classical, more longitudinal incision on the uterus, you can't VBAC her. So the main thing is to know her surgical history. And when you did that first, remember when she came in for the first visit and you asked her all those questions? That's what you want to know. Okay. All right.
I have
Now,
a question. I have a question. So
Yeah.
you know they did that TOLAC, the trial of labor after cesarean. What
Mhm.
would make them? What would you see that would make them stop and go a cesarean instead of letting them finish?
Yeah, what happens is that they also, it's another term, it's the same thing as a VBAC, TOLAC, it's a trial labor after cesarean. What you're doing, they have to go in spontaneous labor. So their body has to produce the oxytocin from the pituitary. Okay. And you can't give them anything. Like you can't augmentate them with Pitocin or give them induction of labor because you can't use Pitocin because you could rupture the uterus. So say you have a patient and so she went into spontaneously. Wonderful. Okay. And so, she's laboring. And then all of a sudden, her brain, her pituitary just stops secreting oxytocin and she doesn't have the labor that she had. And so as long as baby's heart rate's okay and she's able to get up, maybe do some position change to get that contraction to come back. But you can't give Pitocin. So she ends up, unfortunately, that kind of patient can end up with a C-section. Yeah. It sometimes it happens. And I've had patients where they refuse all the way to 42 weeks gestation. She wanted to VBAC so badly, and she never really went into spontaneous labor. Things can happen and things can go sour very badly. So, we tried to get her to deliver, but she kind of fought us on that. How about we use some brain teasers? Ready? These are some questions that are really good. Might see some of these again. The nurse is caring for a woman who is delivering her first baby. So which of the following indicates the woman is in the third stage of labor?
D.
What was that?
D.
D. Absolutely. Good. See how that question was worded? It's a good little question. How about this one? The nurse is observing a patient for a hemorrhage following delivery. So which assessment finding indicates maternal hemorrhage is occurring? Sorry. Let me get something to drink. Select all that applies. It's your favorites.
A, B, C, and D.
Yeah, exactly. Not E, right? Good. Okay. Now, if the uterus, if that E said soft, right, and deviate over the side, that would be more likely. But a firm fundus is not an assessment find that you will find a maternal hemorrhage. Okay, but I'm gonna ask you another question. Let me see if I have it here. Hold on. Okay. I may have it here. The nurse assessing a client post-delivery notes the uterus to be high and displays to the side. This is the question I was going to ask you. So which is the nurse's priority action? So the uterus is high and over to the side.
C.
Huh?
Is it C?
C as in cat?
Yes.
Yes, you are absolutely right. Bingo. Yes. So that's another good question that they could ask you, okay? And they usually do. That's usually a good test question. How about another one? Which nursing intervention should the nurse include for a client immediately after delivery to reduce bleeding and bruising of the perineum? Come on, you got this one. And if you don't,
D.
go get some ice cubes, huh?
D.
Yeah, good, thanks. Okay. All right. Let's see if we can get through some more. We talked about induction of labor. They might have a question on the Bishop scoring. Okay, so, all right, so let's talk about a little bit about induction of labor. Okay, so induction means we're just going to put her into labor, right? So she's not in labor and maybe she's just post dates. Okay, she's her first baby. So we're gonna get her induced. So we bring her in and we're gonna take a look at that cervix. And the cervix, we want to see if it's soft, what's the effacement? If it's short or long. Yeah, if there's dilation of the cervix. How is the cervix positioned inside? Is it interior, posterior? And what we do, we look at the station of the head, we look at where the baby's head is. And if a score is below 6, okay, then we cannot induce. She's got a low Bishop score. 6 and below is low. So we want, to set her up for a 2-day induction. All right. So the first day, we have her in the labor room, we have her on the monitor, and we're going to use cervical gel. That's a prostaglandin gel. And we're going to put that gel up by the cervix, all right? And we're going to let her contract. And she will contract all day, all right? And, it's a long day, but what it does, it helps soften the cervix. So then your cervix starts to dilate, and then it starts to efface. And then it used to be posterior, but now the cervix came around interior. The baby's head is still at maybe -1 station, but now her cervix is favorable for induction. Because when you do an induction of labor, you want to be successful. You want to have a baby. So the Bishop score is a good way, it's a simple score to use when you're doing a induction of labor. Okay, because then the next day, what you do is you rest her for 24 hours. Okay, so at the end of the day, you take her off the monitor, she can take a shower, she can, do what she wants to do. And then next morning she comes back to the labor room and you start the induction of labor using Pitocin. Pitocin is the same, is a synthetic form of oxytocin, and it's a very powerful drug. Okay, it's a high-risk drug. And so you have to use it in milli units, very tiny. And we usually have them on a pump, okay? And of course, you'll have an IV, and she'll be in the labor room, and she'll be on electronic fetal monitoring. And she can't go out walking. No, she has to be on the monitor the whole time because Pitocin can cause hyperstimulation of the uterus, okay? So then she would have what we call tachysystole. She would have a lot of contractions. Hyperstimulation of the uterus causes a lot of contractions. And then that could make the baby's heart rate go down. So you have to be very careful when you use Pitocin. And when we go back to that gel, I want to make sure, because this is always a good test question. When they're going to use the gel, you want to make sure your patient first goes to the bathroom. Okay, because when you put in the gel up by the cervix, there's nothing there to keep it there. Okay, so if she gets up right after you put in the gel's gonna come down. Okay, it's not gonna do any good to the cervix. So you want to make sure your patient goes to the bathroom before you put the gel in. Make sure everything is done because you want her to not get out of bed for at least 2 hours after you put it in the gel, because you want the body to absorb that gel. All right. And get her to be contracted. That's how we do a 2-day induction. And it really works out good doing that Bishop score because, and they can get very upset. The patient can get very upset. Oh, the doctor gave me, told me my score was too low. I had like a 5 or 4 and he's not going to do my induction. Well, that's okay. We'll do a 2-day. Okay. And we'll get the baby out. All right. We're going to just do a little different. We're going to do the prostaglandin gel first, and then get it softened, and then get you ready. All right, so that's what that's about. And then the other term is called augmentation of labor. And what happens is their patient came in and she was laboring, and maybe you gave her an epidural. Okay, epidurals are great, but they also can decrease your contractions of the uterus. So now you have to augment, you have to add to. That's what augmentation means, is to add to. So now you're going to add to her labor by giving her Pitocin, very small amounts, just to get it going again. The main thing with Pitocin is that one, you have to do a good intake and output. And number two is got to monitor the baby. And you got to be very careful with Pitocin. It's very, very strong. You can really cause that uterus to get hyperstimulated. Okay, hyperstimulated. All right. So when we have some, of course, when you have, going to do an induction labor as such, and I told you, Pitocin is a very high risk drug. You have contraindications. Okay, it's not everybody can have it. You have a placenta previa, you're not going to induce. You're not going to put a patient in labor if if she has a placenta covering the cervix. Can't do it. Okay, you'll kill her. She'll hemorrhage. If she has a cord prolapse, you would never put that patient to labor, because the cord is when you have a uterus, when you have a cord prolapse, the cord is coming down around the baby's body, and you can kill the patient, kill the baby. Okay, so you wouldn't do that. These are C-section patients. Abnormal fetal presentation, maybe like I told you, transverse lie, frank breech, full breech. You're not going to induce labor. No. Even they got here, high station of the fetus. And the baby is what we call blottable, -5 station. You would induce too soon. You're not gonna be successful. If you have herpes, the active lesions in the birth canal, you're not gonna do that, because herpes can be deadly to the fetus. And then, mom has a planetoid pelvis. Okay, you learned that pelvis was the most unfavorable for a vaginal delivery. You're not going to be successful. Okay, so you wouldn't do that. And if she had a previous classical incision on the uterus, you're not going to induce labor, because you could rupture her uterus. So it makes kind of sense. And then, of course, now we have some complications. So we're moving right along here. So hang in there with me. So these are different complications that you wouldn't, could happen during labor. Okay, a lot can happen. It's a high risk, high litigation area too. Everybody wants to have a healthy baby. So these are things we went over. And amniotic fluid emboli is in there too on that. And that's when, you can lose your patient very quickly. The amniotic fluid actually gets into mom's circulation and can go up and cause her to have hypotension, and therefore you can lose your patient. I lost a patient that way. And so amniotic fluid, it occurs very, very, very quickly, by the way. All right, let's move on here. Let me see here now. We talked about episiotomy already. Okay, so I'll move to redo that. We're talking about forceps. And here's your forceps. They're stainless steel. These cause problems to the fetus, but you'll have that in newborn. So we'll skip over this, but just know that these things are assisted devices, and there could be a question about that. So, you use those during the second stage of labor to help mom get the baby out. Okay, let's see here. How about a vacuum extractor? So this what is the vacuum extractor looks like. So it's got a circle here, I'm gonna get my pointer. It's right here. And this goes on the baby's head, not on the fontanelles, but on the side of his head in utero. And here's your pressure. And so when mom pushes, we use this to help assist the baby come out. Okay. All right. And baby can have a little mark on his head because of this. It'll be a circular mark on his head. Okay. All right. So if I ask you the question, what would the nurse expect to assess an infant who was delivered with assistance of a vacuum extractor? Which one would you say?
D.
D, thank you. All right, let's skip over. Let's see, oh, it's the same one. Okay, all right. All right, so the fourth stage of labor is your postpartum. Okay, so for postpartum, the first 2 hours, it's very important, especially the first hour, 1 to 2 hours, yeah. And so this is your fourth stage. So you take your vital signs, make sure she doesn't have a fever, right? Fever and pulse. It's normal, guys, to have a lower pulse after delivery. Don't forget, she's going to lose a lot of blood after delivery. Even though the cardiac output during pregnancy is 45 to 50% increase, it's still going to be a lot of blood at birth, okay? So she have a more of a bradycardia. If you find during that stage, or maybe now she's on the mother baby unit and her pulse now has jumped to like 118, 120, now you're running an tachycardia, check for bleeding, okay? This is a big problem during the 4th stage of labor, is bleeding, hemorrhaging. She could have a soft, boggy uterus. What do you do for a soft, boggy uterus?
Massage the fundus.
Massage the fundus, right? Get that fundus. So check that, And so now you find maybe it's high, it's deviated over the side. So you're going to empty, right? Okay. Get that, so you can get it under control. You probably have to give her some more oxytocin. Okay. Call a physician, right? Okay. All right. So you got to work very quickly. And the main thing is that tachycardia is your first sign that your patient's in trouble. So you want, and during the 4th stage, you want to check that bleeding. All right, good. And another problem can happen is that she can throw a clot. Okay, so a lot DVTs, deep vein thrombosis, is very common. Okay, it gets down into that saphenous vein. You get a blood clot, and you have valves in that saphenous vein, and sometimes the clot gets around as a valve and starts to travel up the circulatory system, go right into the pulmonary artery and cause you to have a PE. So you want to, if your patient is complaining of pain in the calf, you make sure you get down there and assess her. It could be red, swelling, and pain. You think right away thrombus, okay? So you call physician. And your patient could have maybe some tachypnea, dyspnea, all right? She's having trouble with breathing and it's real tacky. So you call the physician, you get an order for a venous Doppler study. He does a venous Doppler study and confirm you got a clot or you're okay, all right? And you got to check it out, And that's called a Holman sign. Holman sign is not good if it's positive, because then you got a clot. Okay. That's part of that postpartum in your book is called bubble heat. Okay. That's part of that assessment during postpartum. Okay. All right. Kidneys. The kidneys will come back. Everything comes back. It'll come back. And you want to make sure she's urinating, and you want to make sure she's emptying her bladder so that the uterus doesn't get displaced. Okay. Because displaced, uterus due to a full bladder can cause your patient to hemorrhage. All righty. Then we have our C-sections. And I always tell my patients 2 ways to have a baby, vaginal or cesarean. And you have to be careful with people's psychic, because the psychic is so important. That's one of the pieces of labor and birth process. And it comes in when they just didn't have a normal labor, or she didn't progress, okay? Or she's a failed VBAC or TOLAC, and you have to do a cesarean. They get very, very upset. Now your placenta previa, which is your placenta now is over your cervix, you have to do a section. And if you have an abruption, you're going to end up with a section. When you have a previa, since we're there, tell me what kind of symptoms do you see? What your patient's gonna tell you?
Bright red bleeding, but no pain or minimal pain.
Painless bright red bleeding. You got it. Painless bright red bleeding. That's always on the test. And then what else? With abruption. What's an abruption? How do you know your patient's abrupting?
Dark red blood or no blood and like a board-like abdomen, like
Yeah.
hard.
Yeah, exactly. Yeah, she can have dark red blood when it comes down. It can be not as bad as a previa, but it's bleeding. Sometimes it's occulta, sometimes it hangs high. But she'll have a board-like uterus. Okay. That's usually a good, those are usually good test questions. All right, C-sections, if they have twins, triplets, you know that. And the only thing about twins and triplets, with these kind of cesareans, you have to be careful of the uterus. With twins, your uterus is going to get over distended. Okay, it's going to be larger. So now it's going to have to shrink down again. All right. So she's going to have a harder time with those afterbirth pains because they have to contract. All right. All right, let me see here. Let me go more test questions. So, which will the nurse anticipate assessing in a client following a cesarean delivery? All right, so select all that apply. So what
Would
would
it
you?
be, would it be all of them?
Yeah, exactly. So I was going to say to you, what will the nurse be looking for? Okay, or looking at? These are everything. The incision site or dressing, okay, your lochia, okay, urinary output, you got your catheter in, okay, your vital signs, remember pulse, very important. And then temperature, very important. And then your fundal assessment. You're still going to do a fundal assessment on cesarean. Okay. Got to make sure that uterus stays firm. Otherwise, your patient's got a hemorrhage. All right. Which information will the nurse include when discussing Kegel exercises with a postpartum client?
I only know A. I'm not sure about B. I don't know when you would start them.
You are absolutely right. A. A is help. What this is usually a test question about Kegels, but they want you to remember help strengthen the muscles that involve in urination. Good. Okay. All right. We talked about APGAR already, and the reason why. All right. Let's go here. We talked about thermoregulation. See, we've done all this already, so I'm just going to skip over anything. And let's say, when you're looking at the baby, make sure that you got the ID bracelets on. That's always a good test question. Before they leave the OR or the labor delivery recovery room, okay? You always want to make sure that you got those ID bracelets on. Okay, they have 4 pieces to them, and they all those numbers have to match, and they come together. They come, and then you break them apart. You get one, you fill out one, give it to mommy. One goes to daddy or the partner, and then 2 for the baby, and then put one on his wrist and one on his ankle. Okay.
What would we be looking for with sole creases?
Yes, when you're doing the Ballard score and you're figuring out gestational age of the infant, you're going to look at his sole, because if he's a preemie baby, only about 1/3 of the sole will have creases. If he's a term baby, going to have more of a post-term baby. He's got his whole foot that's going to have creases. Yeah, and that's called the Ballard score. And we go into more of that when we talk about newborn. I think it's chapter 12, I believe. But we did touch on it in these chapters too that you're going to be tested on. All righty. So this one here, I think you got this one. So like, this is a good question. This is how the ID bracelets would be. The question would be asked: which security measure will the nurse take when bringing the client newborn from the nursery to the mother's room?
D.
Yeah, D. That's the only one. Yeah, she can tell you, I'm sure I'm Mrs. Jones, but maybe you don't know her. Maybe you're a new nurse coming on that shift. You know what I mean? So yeah. Okay, good. That's really important, by the way. Now, I did make a slide up for you on the normal vital signs for infant, because HESI always likes these kind of questions. And so they'll give you a big scenario. You might have it on your test too, where you have to identify which one is abnormal. So I always say, if you know the norm vital signs, you can pick out the abnormal, and then you can select the intervention that's appropriate for that vital sign. So this is why I put this in here. So normal respiratory rate is 30 to 60 breaths per minute. And your heart rate is like, in utero, 110, 160. And how you evaluate a baby's heart rate is you do an apical pulse, okay? So you get your stethoscope and you're going to listen, and you count for 1 full minute, okay? You can't go for 15 seconds and time for 1 full minute, All right. And then the temperature, you always want to make sure that baby is kept warm. Okay. And you know, you gotta make sure you don't get them too warm either, because you don't want a baby hyperthermia. So you want to make sure that he stays in like 97.7 to 98.6. And you do it axillary, okay? A lot of students are still putting down rectal. No. Okay. Too much damage has been done to babies doing rectal with from nursing. So we don't do that. We do axillary. All right. So those are usually good test questions. So here, which of the following intervention best promotes bonding? Now, bonding is what happened right after delivery. So which one would promote bonding?
B.
Yeah, B, skin to skin. Okay. Bonding is more sudden, put it more sudden connection, okay, with baby. You know, you have the baby, we put the baby right to mom's breast, as long as everything is good to her chest, and we can do an APGAR, we can do everything right there on mom's chest. That's skin to skin. That promotes the bonding. Now, attachment is something different, and attachment more takes time to develop. Okay, like when you get attached to something is because you had time to get close to that person. Bonding is real instant. Okay, so that's the difference between bonding and attachment. All right. And breastfeeding. Breastfeeding, you got the colostrum, which has protective antibodies. Okay. Really good, guys. Hang in there with me, Geraldine. We're almost finished. And but you could have a question on colostrum. They could throw that in on here because it wasn't one of the chapters. So you have the colostrum. Now, you have two hormones that are responsible for breastfeeding. You have prolactin, which stimulates the production of milk, and then you have oxytocin. Now you know that oxytocin comes from the anterior pituitary. That actually plays also in breastfeeding. It helps the letdown. It causes the milk projection or ejection to come down. So again, oxytocin is very important. Just to let you know that oxytocin is also the hormone of love, since yesterday was Valentine's Day. So now you can share that with your loved one. All right. So okay, so this is another question how this could be asked. The nurse is discussing the different phases of milk production with the patient. So which phase of milk production will the nurse refer to when talking about the phases of milk production that contains protective antibodies?
B.
B. Yeah. Well, that's a good question. All right. All righty. Let's go here in case they start on the test. Let me see about latching on. Make sure that the baby gets the full areola in his mouth, not just the nipples. So make sure that this all area gets in his mouth, just so you can see here, because we don't want mom to have mastitis. If the baby just latches on to the nipple, baby will make that nipple sore, it'll crack, and then she'll get a condition that this is what it looks like. That's mastitis, and that's very painful. So we want to make sure that they latch on correctly, and then once they're latched on, then you break the seal. And how that happens, you put your finger, moms put their finger in the side of the mouth, and that will break that suction, and then the baby comes off the breast. All right, let's do a couple more brain teasers. Okay, so which of the following indicates successful breastfeeding is occurring?
A.
A. Okay, that's always a good question. Which nursing action best provides a postpartum client pain relief from breast engorgement?
A.
No.
D.
C. Good. Put some cold packs on there. Good. They put the cold packs on between the breastfeeding, and then when it's time to feed again, they can put a little warm compress on there so that for the milk. But that works good. How many calories does mom get? Extra calories is she breastfeeding? 500. Okay, 500 calories. Okay. All right. Let's see here. I think that chapter had about a little bit about weaning and gradual weaning off the breast is the way to go. Okay, you have to eliminate one feeding at a time because breastfeeding is very comforting to the baby. And if you just decide one day I'm not gonna do this anymore, not only were you getting gorged, okay, because the milk was still coming in, but the babies also get psychologically they get affected. So you want to make sure that you do this correctly and gradual. So we go over this with moms, and which one you eliminate last would be the favorite feeding. Usually that's the nighttime feeding that you would eliminate as the last one. Okay. All right. Let's see here. I think we're at the end, guys. Okay. All right, we talked about all that. Let me see, we talked about that. Okay. And let me make sure I touch on some of these important things here. We talked about that already. That's okay. Oh, it's all repeating. All right. I think we did pretty good. Let me just go over some of the complications here with preeclampsia. I think that's on this test. Let's see here, premature rupture. All right. Be sure that you understand about magnesium sulfate. And because what do we use magnesium sulfate for?
Preeclampsia.
Preeclampsia. Now, magnesium, the way it works, is also used for preterm labor. But yes, for both. What do you have to worry about with magnesium sulfate? Because it is the central nervous system depressant, right? It kind of quiets everything down the body. To worry about it affecting the her respiratory, and of course her reflexes. And the reflexes are the first to be picked up. Okay, the reflexes. So she gets hypertonia. So we gotta make sure, what can I use to reverse the effects of magnesium sulfate?
Is it calcium gluconate?
Yeah, you got it. You got it. That's always a good test question too. Calcium gluconate. Good. Okay. All right. So when you're using it as a tocolytic, okay, this I told you is good for preterm labor also. So you're using as a tocolytic, which means we're going to stop the contractions. It does work very well. All right. And we don't want to deliver that baby too early, do we? We always want to keep these babies in utero as long as we can. But what can we give mom if mom is in preterm labor? We're giving her magnesium sulfate to slow it down as a tocolytic. What can we give to mom to increase the production of surfactant in the baby's lungs?
Betamethasone?
Yes, betamethasone. Betamethasone. Good. Okay. And we give that as 2 injections, 24 hours apart. And we do that to increase the surfactant. Good. All right, good. You got that. Very good. All right. All right. So not only do we have preterm labor, okay, that we don't want these babies to go in to deliver too soon. So preterm is anywhere from 20 weeks to 36 and 6/7. That's preterm. All right. And we like to keep these babies in as long as we can. That's why we do what we do, but magnesium and the betamethasone. Okay. Now, on the other hand, we do have a problem with the other for prolonged pregnancy. All right, where their bodies don't go into labor. Okay, and they can go to 41, 42. Going past the 42 gets a little risky. So you would start doing like non-stress tests on these babies, usually about 41 weeks. We start looking at the baby, making sure that everything's okay in utero. All right. Then if everything's okay, the placenta is still functioning well, we can keep going. But remember, as the pregnancy gets longer and longer, the placenta will age. And the placenta, delivers oxygen and nutrients to the fetus. Well, all that will diminish because placenta, what happens, the placenta calcifies, gets old, okay? And it'll get hard, it'll calcify, and it will not give the oxygen and nutrients to the fetus. So the fetuses may lose weight in utero, and their skin gets real peely at the end, and she could have a decrease in amniotic fluid, and you can start having some fetal distress because you have more cord compression. So things can really get rough at the end if they go too far. And then, of course, the baby can have meconium. And so we have to be very careful. And these babies of prolonged pregnancy, due to all that, can come out with low blood sugars. Okay. Hypoglycemia is not good for a baby, as we found out. Like hypothermia causes hypoglycemia, and hypoglycemia causes respiratory distress. You can actually write that down and how those connect. Okay. So this is prolonged pregnancy. And then we talked about a little bit about prolapse umbilical cord, how the cord comes down. Those are emergencies. Those when that comes in. I remember a patient coming in, and she came into triage, and I was checking her. And when I went to check her, I could feel the cord pulsating. The fetal heart rate was low. It was like in the 90s. And so I had her on her side, and I had my hand in there. Once you discover it, I can't bring my hand out because what I had to do with my fingers is push the head up off the cord. So I was keeping that baby alive by pushing the head up off the cord. And then I called my OB-GYN, and we took her to the OR. I never took my fingers out of there. Okay. I went to the OR with everybody underneath, holding up this head off the cord. And so we did save the baby, and baby came out, had a little low Apgar, but was resuscitated, and then went to the NICU, and baby did good. Okay. Again, that was an emergency. Also had a patient come in, and she was bleeding, and baby's heart rate was low. So we figured out she had ruptured uterus. She was a prior cesarean delivery. And so we ended up in the OR, and we opened her up, and baby was floating in her abdomen. The uterus had opened up, and the baby had come out of the uterus and was just floating. Everything was floating. The placenta was still intact, and the baby was intact. Everything was still there, but it was just outside the uterus. Those things do happen, and they are emergencies, and that's why you have to be very much on alert. All righty. We talked about beclomethasone, okay, and the reason why, and that's always a good test question. And then our postpartum complications, okay? Shock, okay, hypovolemic shock, we talked about that, and hemorrhage. And you want to make sure the fundus of the uterus is firm. She can throw a clot on you. We talked about that Holman sign. Puerperal infections during the postpartum period. Okay, that's why you want to monitor her temperature, anything over 100.4. And you tell her too when she goes home that if anything over 100.4 needs to be reported. Okay. Subinvolution. Now we talked about involution very well, but subinvolution is just a delay in that uterus involuting. And the biggest delay would be what? The retained placenta fragment. Okay. That would cause the uterus not to contract down as it should. And it's called subinvolution, and she would be bleeding, okay, and have maybe her lochia would change from lochia serosa back to rubra. We talked about that, and they're at home during that period, and so they have to be on alert. Okay, all right, and then mood disorders. We got postpartum blues, and the postpartum blues are what? What are postpartum blues?
Like a low mood, kind of back and forth, but not as serious as postpartum depression.
Right. The mood is I'm sad, right? I'm sad. I've got the blues. Maybe I'm overwhelmed, I have nobody coming over and helping me. I haven't taken a shower, and I'm just, I love my baby. I'm taking care of the baby, but I'm just kind of sad and I'm tired. And then if that's not recognized and taken care of, then it can get worse. She can go into postpartum depression, and that's more of a long-term serious kind of condition. And she loses interest even in the baby. She's not going to harm the baby, but she does lose interest in life, and so it is more of a profound state of the psychic. Now, you can have postpartum psychosis, in which a lot of ladies who have disorders such as a bipolar disorder, they are prone to this. They get into a dark place. They hear sounds and hear people's voices and almost like a schizophrenic type of deal. And this is where we've had patients that can kill their babies. That's called infanticide and also suicide. Okay, mom can kill herself, and then she kills the baby first, then kills herself, or just kills the child because she's been told the child is it's not your baby, is an alien, all this kind of stuff. It's they need help. They need psychiatric help. And so you have to recognize that. And I think today we recognize that more and more. All right, let's see, Miss. We talked about hypovolemic shock. Okay. All righty, just kind of going down here. Hemorrhage, and we talked about hemorrhage. Let's talk about urinary atony real quick here. So I said this is a long one because this is a lot of chapters. So what happens is that it's a uterus without tone, basically. And so again, the blood collects within the uterus. And I talked about overdistension with twins and triplets, when the uterus gets overdistended. Maybe she had polyhydramnios, a lot of fluid. And again, the uterus gets overdistended. That can cause the uterus to have less tone, retain placenta fragments, things like that. Oh, and then, prolonged use labor drugs during the labor can relax the relax the uterus. So these things can make the uterus be without tone. And you pick it up by checking the fundus of the uterus, and you empty her bladder, make sure that's empty, make sure she has oxytocin going. A drug that probably you'll see this on this test, I think it's on this one, is Methogen. Methogen is used also to control bleeding associated with uterine atony. Methogen, you have to make sure that you take her pulse beforehand, because you don't want to give Methogen to a woman who's got a high pulse because it increases her heart rate. So, but usually if you got someone who is in hypovolemic shock, and usually you have to monitor their pulse and make sure that you can give that Methogen. Another one's called Hemabate and Carbopress. Carbopress is another one. Okay, let me skip down here. I want to make sure I get everything here. We're talking about subinvolution. You guys will have access to my slides here and more of my brain teasers if you like to do those. Let's see here. Oh, this is a good one. Your patient is 5 weeks post-vaginal delivery. And so during the doctor visit, the patient states that she notices a foul-smelling drainage and pelvic discomfort, and she's been running a slight fever. So the nurse relates these findings to which of the following? These are infections, right? So which one of these tells you that what she's got? Remember, up here in the question, I go back and I said, what's this question actually asking me? Gave me a lot of information. Oh, she's got a foul-smelling drainage and pelvic discomfort. So that means it has to be within the endometrium. So see how I answered that?
Mhm.
And then I go down to my choices, and there's 2, endometritis. See? Now you could have jumped. A lot of students jumped to 3, but again, if you just take a few minutes or a few seconds to ask yourself, what's that question actually asking me? You answered it. You got it? That's how these nursing questions are, okay? But had nothing to do with involution, and of course, mastitis is inflammation of the breast, so that wouldn't be. All right, so where am I? Oh, okay, I think I'm coming. I think I hit on placenta previa and preeclampsia. Preeclampsia, just to let you know, just go back and make sure. I think it's on this test. Let me see. Preeclampsia is just hypertension, and it shows his bad side. How do we say the bad side? The horrible time is after 20 weeks gestation. Okay, and so you got patient can have protein in the urine, hyperreflexive. And so you want to jump on them, give them magnesium sulfate. There's a magnesium sulfate again. Usually about 4 grams loading dose helps. And the main thing is, guys, to prevent a seizure. That's why you're giving magnesium sulfate, because it decreases the brain activity that would cause the seizure. So you want to decrease the seizure. Once she has a seizure, it's called eclampsia. Okay, so these patients can have abnormal liver enzymes. Their liver can enlarge, all right? And so you want to make sure that, you assess for epigastric pain. All right. Okay, let me see. We touched on previa, we touched on that. Let's see here. We touched about slow breaths, relieving hyperventilation. I'm just going with my notes to see, make sure I gave you everything that I want to give you. Let me stop sharing. Oh, here, my end slides. A lot of students miss out on math, okay? Don't be one of those students to miss out on math. If it says round to the nearest 10th, round to the nearest 10th, all right? Follow the instructions. A lot of students are just around, I don't know, it says round to the nearest 10th and they round to the whole number. Oh, okay. So read that. Don't miss out 2 points for that, okay? So, and you all been doing your math calculation